Good evening, everyone. My brief today is to talk about revision knee replacement using robotics. At the outset, let me tell you, robotics is not necessary to do good revision. Having said that, just like any technology, robotics helps us to make better decisions, and better decisions lead to better outcomes. And in addition to that, it also helps us execute our decisions well. We all know that the goal in knee replacement and specifically in revision knee replacement is to get a good limb alignment, get a good component positioning, and ensure that the knee biomechanics and the gaps are well balanced. We are aware of standard pathways in revision, and traditionally we did the execution and planning which went hand in hand. In robotic, however, the planning is before the implants are extracted and the gaps are collected even before that. This ensures that we know how the native soft tissue is, and it's a very vital tool to ensure that we use less amount of augments, wedges. The implants that are used are much more biological friendly, and that the gaps are balanced much better than we would do traditionally. In this case, which is a failed left side uni, we start with registration of the femur, and you'll see that most of it is similar to what you do in primary. The only thing that we do additionally is to take a few more special points, and I always make it a point to use right side line to overrule the posterior condylar axis that traditionally the computer wants. The same thing is done on the tibial side. The additional points that are taken on the tibial side include the tibial tuberosity and the distal extent of the tibial implants. So you'll see after I have mapped the tibia, I'll use the special tool, which are these magenta dots, to mark out the tibial tuberosity and the inferior end. Once we reach that, we reach this what I call as the warm-up screen, and once that's done, we collect the gaps. The gaps are collected both without stressing and in medial and lateral stressing. Once you collect the gap, in this case you can see that there is tightness both on the medial and the lateral side. So for a standard implant to go, the medial side is almost 12.9 tight in extension and 12 millimeter in flexion, and the lateral side is also tight. So what I'll do is that, of course, in this case I'll have to increase my tibial cut, and that's what I will do. This has got two benefits. One, that it will reduce the amount of gap that is there for me to build up on the medial side, and two, it will also ensure that my gaps are balanced and I would need minimal amount of lease. So you see, with few tweaks I've got this planning screen correct. I'm not bothered about the medial side here, which is the pathological side. What I want to do is to get my planning screen to our normal side, which is the lateral side. So here, with tweaking the tibial cuts and the femoral cuts, I've got 0 0 on both sides with a 9 poly. Once that's done, we proceed with our bony cuts. This is the planning screen. So this is, once again, we look at the planning screen, take the checkpoints and proceed with cuts. The beauty is that, again, robotics will execute it to millimeter, sub-millimeter and sub-degree accuracy. All the red point that you are seeing is on the account of the bone defect. So the darker it is, the more defect is there. So in your mind, you make sure that whether you have achieved what you wanted to start with. Once the femur is done, the same thing goes with the tibia. You use the burr to remove everything that is magenta, and you want to get them as white as possible. And once that's done, you can go ahead and start with the bone defect management. You'll see that this is how the darker ends means that you are more than 5 millimeter down, and the light red means it is around 5 millimeters. So you know that you will probably require, and this is sort of an unconstrained defect. So by doing or running your burr, you have made sure two things. One, the large part of your platform is ready, and the second is the area, the defect that you need to take care is contained or uncontained, and what is the degree of or the depth of the defect. Once that's done, you can recollect the gaps, and in this case you'll see that my final thing is around 3 degree varas, and I'm very happy with this. And this is how the final balance looks. So we started from there and we reached here. So you'll see on this screen a 2 degree varas has been achieved, 3 degree varas has been achieved, and we have used only a 9 millimeter poly, and you could see that the graph was complete parallel. And this is how the x-ray looks like. You will almost looks like a primary joint, a CR implant, a 9 millimeter poly, a minimal metal on the medial side, and an excellent gap throughout the range of movement. In short, robotic is an invaluable tool in my opinion for revision TCAS. It helps in the key alignment of alignment, joint line preservation. I think it's very important. It gives you an insight on bone loss management, and all of this leads to less inventory on your table and more peace of mind. I believe that, like any technology, when our experience and familiarity grows, we'll use it and leverage it for better uses. The fundamental, however, remains the same, which is to get good platform, good alignment, good balance, and personalization and versatility of the platform is very important to ensure that the surgeon is comfortable. And I thank you very much for your attention and welcome any question that you may have in this regard. Thank you very much.